Hello everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Ava Kelly. This week, we are giving you another presentation from the 2025 Medicine in the Mediterranean Conference. Each January, the college runs the MIM conference in Malta. We focus on the practice of medicine in remote, austere, and resource-limited environments. Here is a talk from TacMedNorth North, who are a volunteer medical unit based in Ukraine that runs medical courses for those working on the front lines. They also spend a lot of time working at the stabilization points there. Here is Vlad Chumachenko.
All the countries and all the representatives here, we feel support in Ukraine, and that support huge. I mean, we get knowledge, we get experience, we get equipment, and the only thing we can give back is our experience. So we will try to do our best to share what we have right now in Ukraine. We have a few issues that we need to discuss. First of all, photos. Most of the slides, it's okay to take photos of them. There will be a couple of them with sensitive information, and I would say, please don't take any photos. It's nothing super dangerous there, but still it's mine and your safety in general. Second one, there are going to be a lot of casualty photos. It's photos of our medevac unit. So if you don't like bloody photos, which you probably like, just close your eyes or leave the room. Questions. Please ask questions during the presentation, because if I get Eric correctly yesterday, after the presentation we have a continue as a discussion, so we can start immediately. So if something blows your mind right now, just raise your hand and ask a question. The last thing is, sorry for my English, it's not perfect. My Ukrainian is better, but yeah, not everybody speaks Ukrainian right now. We have a tradition in Ukraine, and I'm sorry to bring this drama to that room, but we can be here, I mean me, Nastya and Misha, North Unit, only because somebody pays the price on the front line on a daily basis, and there are a few of our friends who paid the biggest price. So please stand up to remember heroes. Thank you. So, who we are? We are called TacMedNorth North. My name is Vlad. I have Misha and Nastya together with me. We started this unit together. And what makes us different from most of you? You choose medicine as a part of your life. We didn't choose it. We had no choice. When the war started, the only choice that we made is that we want to fight for our country with the best that we can, and somehow it appeared that the medical or pre-medical part is the best area that we can help to our country, because most of us are mountain rescuers in the previous life and basic first aid instructors in the previous life. So we found a volunteer medical unit. Right now it grows little by little. The first baby steps were done with the support of MSB as a Swedish contingency agency, as a governmental agency that prepares Sweden to future conflicts and disasters. Right now we became a certified NAMT center in Ukraine, which is a great opportunity for us to bring the best training to our combat medics. We are part of the big unit which is called Extraordinary Tactical Medical Center. It's controlled by medical forces. It's a bunch of volunteer medical units who are recognized as a training and a medevac providers by Ukrainian Defense Forces. At some point, it will be in my presentation, we met guys from the Quorum, and right now we're proud to represent this DCR program in Ukraine together with Quorum guys. And we get a huge financial support from the project called American Rescue Project. They met us online and then offline and started to support our unit financially. So we are a volunteer medevac unit, and as I said, we had no choice, and we had this small video about the reasons that made us to combine that unit together. So basically we do both. We train service members and the combat medics who are gonna participate in a combat environment or already doing it, because we were one of mobile training units and we not train in a classroom setups. regularly we go to the place where we need it the most. And also we are participating on the front line as a case evac, medevac, and a casualty collection point medics. So we trained till this moment 29,000 students, different level from I7 level to DCR together with Quorum guys, and we helped 900 nearly 900 casualties. And the thing we will discuss today is challenges that we meet, and we're going to discuss both. I mean challenges that we meet as instructors and challenges that we meet as a trainings, because the main reason we decided to participate on the front line as a medevac and a case evac unit is to become better as an instructors, is to bring better highlights to our students, to our combat medics, etc. There is a really popular sentence in Ukraine that TCCC doesn't work in Ukraine, which made me angry all the time, because like I've been on the front line, it works, and it works perfectly there on the front line. And we decided to make a small study. At the beginning it was just for ourselves, to understand, does it work correctly? What should we highlight to give a better understanding of how to train our combat medics? And we started analysis of the data that we can get from stabilization point. For you to understand, stabilization point, it's a kind of roll-wall facility, which is not the same in different brigades. Some brigades are more trained and more equipped. Some brigades, it's just an old table and a couple of bandages and IV clear fluids only. So we could get some data from the stabilization point, and the main task was to understand a pattern of injury. So let's go further. And after that, it became interesting for us, what about combat and non-combat casualties? Because one of the concepts you should understand, and probably you know it, but I'll bring it to you again, the amount of defense forces is almost 2 million people right now in Ukraine. It's guys, men and women who are somehow actively protecting their country. And we call ourselves civilian army. Like most of the people on the first photo, except 2 of them, I mean our dead comrades, most of them were like rock climbers, IT specialists, whatever, but not a professional army officer or something like that. And a great amount of people are already like 40 years plus, and they have health issues already when they have been mobilized to protect their country. So that statistics is 3,500 plus cases from one of the frontline hospitals. It's Role 2 facility in our reality. And we see that amount of non-combat diagnosis is huge. So stay with me with that thought that CMC course is not enough for those who are going to treat casualties in the front line, in the winter, in the dirty blindage, in a cold environment. They should get their nursing skills. They should understand nursing from not capital N, but from small n, and we'll come back to that later. And 1,265 combat wounds in that slice of the statistics. And that's the second winter of Donbass campaign. So it's Bakhmut was the first one, it was the second one. And like the situation, I wouldn't like run through the whole numbers, but you see it's like more or less continuously the same. So nothing changes dramatically in 1 year in the localization of the wounds. Because like the war is the same, we still wear a plate carrier, mostly not protected enough. We cannot change tactics dramatically right now. We don't get more guns to protect our positions. So that's the wound patterns that we have for now. And the main reason I started digging in this documentation, in those Excel files, etc., because our medical forces don't bring anything on the table. The only data they bring into conferences and to meetings is the data from hospitals. And they get a really great statistics of survivals in hospitals, because the most of the dramatic statistics happens pre-hospital. So injury pattern is a training tasks predictor. When we prepare to train our combat medics, right now with the help of this wound pattern, we understand that March pose, and the TCCC works perfectly for us. But we need to highlight some stuff. We need to understand how to teach needle decompression. We need to understand how to highlight like a primary assessment. Like a big deal for us is a skill station on raking of searching for this penetrating torso trauma right now, because we see thousands of missed penetrating torso trauma. The next statistics you can take photo if you want, because it's our Medevac team statistics only. My Medevac teams, we have 2 Evac cars and 2 Medevac cars, but we not always work in them. Sometimes we work in a casualty collection point and stabilization point. Since May till December, we were working in Vovchansk, it's a Kharkiv region. And it's the casualties that been like passed through our hands, if I can say so. Non-combat casualties is 17% of them, because it was like mostly warm period of time. No, not a big amount problem with cold, kidneys, like typical winter problems that we have right now. 70% is a drone wounded casualties, and non-drone combat injury is 65%. It doesn't mean that the situation will be the same in the whole front line, but in Kharkiv region the situation is like that. The main reason, it's a forest region. When we're talking to the steppes of Donbass, probably the amount of drone injury will be bigger there at that moment. And we started to investigate what about the drones, where do they hit our soldier, what should we like what should we prepare to train our combat medics. So it's 100% of soldiers injured by drones, 37% of them got a TBI, 29% got upper shoulder, upper arm penetrating trauma, and only 4% in between have the same, like TBI and upper torso trauma. And when we're trying to get to the situation itself, it became obviously that happens when you're trying to do some job, you're looking into something, you're looking into your optics, whatever, and the drone hits a blindage, a position, whatever, and it mostly happens when they are driving the vehicles to the front line and back to do medical evacuation, bringing ammo and stuff like that. Because at that moment they are mostly wearing ballistic goggles, wearing helmets, and it doesn't influence their head so much. So we have those two future challenges. It's a percent, like it's a 40% of 100 casualties that got a combat trauma from the last year, and you can see that you still have a big percent of penetrating torso trauma, a huge percent of penetrating hand trauma and concussions, and still like limbs is the biggest challenge, like in every war. And it's like we separated drones only, so those casualties were like wounded by drones only without any mines or shooting or whatever. So again, we have legs, arms, a big amount, like 28 probably percent of penetrating torso trauma, and a TBI. So when we're talking about TBI, is one of the biggest challenges that we meet, because you know it's not so much you can do pre-hospital with that kind of trauma. So we're trying to work with the airways with the best possible way. The situation like that is pretty typical. You see a great amount of small shrapnel wounds. We call it VOC 17 allergy. It's a joke, so it's okay to laugh, because they drop in VOC grenades from the drone, and they have literally tiny shrapnel. So it's multiple wounds, but none of them are massive bleeding, hopefully. And we feel support through the understanding by TCCC committee when we get new guidelines in January 2024. I cannot assure that it's like been encouraged by Ukraine or whatever, but we get a new way, a new guideline how to work with TBI, how to work with airways, and it gives us a light in the black tunnels, because we don't have doctors frontline. Doctors will appear only on the Role 1 facility, and we feel a huge lack of this kind of personnel on the Role 1 facility. So the first challenge is the TBI, and we're trying to stick to guidelines. The only problem that we have with the TBI, those kind of fluids that TCCC proposes to use it, they called hypertonic, yeah. The next challenge that we met is a medical personnel doesn't use TC3. So everybody is saying TC3 doesn't work in Ukraine, but most of the mobilized medics with medical diplomas doesn't use TC3. It's not because they're bad people or whatever. They've been doctors in their hospital doing what they can do in the best possible way. And at one point, they've been mobilized to the army and thrown away to the Roll-Wall facility to do damage control resuscitation, which they never been trained to do. And they get used to do some stuff just because they get used to do. That's why we see a lot of, it's just an example, it's a central catheter, put it into his skull. Only because that anesthesiologist get used to put central line instead of IO, which he's not familiar with, instead of even tried peripheral IV catheter or whatever. And when we trying to yell that maybe we'll use IO, right now in Ukraine the price is almost the same, you're just EMT, just stay away and don't bother me with that. But there is not every stabilization point can control placement of central line with X-ray or ultrasound. So we come to the challenge, it's just an example, so comes the challenge of a gap between a surgical doctor in a Roll-1 facility and a combat medic in a dirty blindage in the front line. So we find small solution how to fix it, and we're testing it together with Azov Brigade. Right now it's Instagram post of Azov Brigade about that. So they came with a proposal to North to bring their surgeons and doctors to TCCC CMC course. And we were like, oh, really? Do you think it's a great idea? There's going to be a lot of argument. But the results was great. And the main feedback we get from doctors that only right now they completely understand the reason those combat medics doing it pre-hospital in that way, in their environment. So for now, we are successfully continue that project, and I hope other brigades will take it as our experience also and try to run TCCC courses for their medical personnel also. Chest seals, it's our big pain in the ass, and like from my experience, I don't want to say anything bad about any brand, but all of them suck. Some of them suck in the summer, some of them suck in the winter, some of them suck because they're too small, some of them suck because they're too big, some of them suck because the form of the valve sucks itself. So yeah, chest seals is a big pain in the ass. It doesn't work that way that they show in a skill card. It's just an example, but it's only one of the challenges that we have. We train a lot of people in a short amount of time, so we take the simplest explanation we can, give an explanation to a combat medic, and he goes to work with that explanation. Only right now, after like 2 years of full-scale invasion, we try to switch that paradigm to something else. So what do we have here? A pretty big penetrating torso trauma, fast minus. So we check lungs, fast minus, being covered with occlusive dressings. Obviously, probably I would do the same in that environment. Pretty big penetrating torso trauma, fast minus, so no pneumothorax, no hemothorax, nothing like that, just the muscles and the skin damaged here. Let's continue our journey. Same and same, for me not to tell the same story again. So we have a massive penetrating torso trauma. We suspect potential problems with that, but it's appeared it's just muscles, skins, and other tissues damaged. And the most horrible case is here. You see how horrible is that? Pneumothorax here. And the nurse who did triage in that stabilization center, she's just a nurse from the regular hospital. When they see a massive trauma like that, it goes to the shock room immediately, because it's big and it's bleeding and it's like obviously too scary. That guy appeared in our car by some miracle. There was too many casualties in stabilization point, and the leader of the point came to me and said, please, can you take as many easy wounded casualties as you can and just move to like freeze the table and freeze the benches for the new casualties. And successfully there was experienced medic on the shift, Ivan, and he put a pulse ox and found that the pulse oximetry is not great. After that he made like reassessment. If I find this hole just covered with betadine and with some plastic foil just covered completely. And he put a occlusive dressing, give oxygen, etc. Another problem that we meet, as I said, occlusive dressings are not ideal. So sometimes the valves until occlusive dressing, we get it like that. So it's like a ventilated occlusive dressing due to package. but obviously it's not a ventilated occlusive dressing anymore. So the challenge that we meet is that not every penetrating trauma, per torso trauma, is associated with pneumothorax. The amount of unsuccessful needle decompression is pretty big. I cannot come to you with a number. It's just my frontline experience and the medics who I'm communicating with. And in most of the cases, when it's pneumothorax, it's associated with hemothorax. So the conclusion that I heard, if we weren't going to teach advanced skill, maybe we need to switch to that skill immediately. It's that skill in the skill list of the next course of TCCC, Combat Paramedic Provider course. And in that case, we can treat both pneumothorax and hemothorax in some potential possible way. So the things that we are trying to stress right now, number one, maybe we shouldn't train to put occlusive dressing on any hole that we see. And the things that we're trying to discuss with the world right now, maybe finger thoracostomy is a skill that every combat medic should have in a skill set. Not move it to like Role 1 facility because they couldn't sort of survive to that. So we were really happy when we get in new tech guidelines where active bystanders, the lowest tech course, they type non-occlusive vented chest seal, synthetic material placed, just covers the damage. No valves, no plastic, no foil, just covers the damage. Open pneumothorax can be stabilized by himself for some period of time, but you wouldn't cause tension pneumothorax because the valve doesn't work, the valve is covered with blood, and you just sucked to control and reassess your casualty because you've been trained 5 days before going to the front line. Blood is the next challenge that we met on the front line. Like, obviously, blood saves lives. Everybody knows that. Everybody knows it's a deal. And the first problem that we met on the front line, we were working in chassis VR, in the stabilization point, and a really great doctor was working there. And we were giving blood to the casualties from medical personnel stabilization center. And I came to him and asked, why don't we give blood to every shock casualty? And the only reason was equipment. We had no blood warmers in that period of time. We had no refrigerators. So the first problem was logistics. And right now, logistics is mostly on the shoulders of NGOs, with a bunch of NGOs who can present to any medical company equipment like Quantum or MacU to warm blood, not good amount of refrigerators to store blood and move blood from the front line. But then we came to the next challenge. Who is trained enough to give blood? Due to Ukrainian law, only some part of doctors with medical diploma, not every of them, can give blood legally. Again, our government made a step to us, and right now, Tactical Medical North, Pharma Project, Pulse Project, 3 NGOs are partners of Ukrainian Transplant Coordination Agency, governmental agency. So we train them, our instructor train combat medics, and if they pass an exam successfully, they have a governmental certificate that they can give blood pre-hospital in Ukraine right now. And it's became a big deal, our outcome is huge. We have a first miracle in this May, during the Vovchansk counter-assault, when Russians assaulted small town Vovchansk near Kharkiv. On the second day, Kharkiv hospitals were out of blood. So we give blood a lot and we need more blood. And I am on John Quinn's side here, we need universal blood because of cross-matching blood in Role 1 facility, we get more problems than treatment of casualty. It's just a couple of pictures from Transplant Coordination Center, and you see North instructor training combat medics, police assault unit combat medics, how to give blood, how to bring blood, how to test, and how to deliver the most expensive fluid to trauma casualty. Next challenge that we meet in our environment is tourniquet conversion and teaching scars. And the main skill station that we ever seen, and we did the same, and sometimes we still do the same. What do we have? We have tourniquet high and tight. We have one wound, which is like wound packing mannequin. If you don't have any contraindication and you have indication, you do wound packing of one wound, and then you untighten your tourniquet. But in reality, especially during artillery war and the drone war, we rarely see one wound cavity on the high and tight tourniquet. And when you cut the pants, you see the pants covered with blood everywhere, you see the legs covered with blood everywhere, and you can see from 6 to 8 It's the biggest amount I've had, wound cavities in one leg. And every wound cavity potentially is a wound cavity that can bring massive bleeding again on the table. So you should do wound packing really quickly. You should really precisely reassess the limb before prepare your casualty to tourniquet intervention. So we rarely have that way. Most of the time we have that way. Sorry for quality. Like I hope you see there's multiple shrapnel wounds down there. Here you see that 4 people trying to convert to tourniquet because the time of the tourniquet was almost over 2 hours, and we need to do wound packing for most of the wound cavities to try to take off those tourniquets. And the same situation is here, like a surgeon doing his best to take off the tourniquets with multiple shrapnel wounds in the closest possible time. Before we switch to Russians, a couple of videos about tourniquet conversion. Nastya will open it and I will give a comment about that. They are pretty short, but they are just, that's going to be the first one. They prove that I'm kind of not lying to you, probably. So many shrapnel wounds, and all these shrapnel wounds from drones are really small wound cavities, and we're trying to do wound packing as fast as we can with all the tools that we can to apply adequate pressure in the wound cavity. Yeah, you can start. And you can see a second leg, there is a lot of small wound cavities there also. It's tourniquet high and tight. You don't know which wound cavity is potentially bringing you to massive bleeding again. And the second tourniquet conversion is here. Is a surgeon trying to do tourniquet. It's not even a tourniquet conversion. Tourniquet been converted in before, but the combat medic was really shortly and badly trained. He didn't pack correctly the wound cavity, and he decided that he can compensate bad quality of his wound packing with what? Correct, with pressure bandage. So we are having a casualty with a pressure bandage on the arm with the same absent distal pulse under just a pressure bandage. And the thing that we need to do right now is actually to do a tourniquet conversion again by unpacking the stuff, repacking it, and putting a pressure dressing. Let's get to the presentation right now. One of not so obvious, not so popular challenges that we have on the front line is Russians. And I don't mean, I know that they're trying to kill us. It's obvious. Like the were invented to kill somebody, but the problem is that that's the way they treat their casualty. We have a bunch of stories about that. I bring only 2 of them on the table, the one I can show. That casualty, Russian guy, he was left in the position for 4 days with the first aid of that quality, Chinese tourniquet, piece of wood as a splint, and some tape around with a silver tape just to keep the piece of wood. Obviously signs and symptoms of compartment syndrome, so his general condition was pretty shitty. And it takes a great amount of resources for our soldiers and for us as the medics to treat them, because we're trying to stick to conventions and because we need to trade them for our people. We still have thousands of Ukrainians imprisoned in Russia. Second case. The guy it's Nastya's case, so maybe if you have a question you can ask Nastya. The guy, his comrades, Russians, cut his throat on the position and left him to die there. Fortunately, they cut a trachea also, and he was breathing through this improvised stoma with the maggots around and stuff like that, and he was brought by our soldiers to our hospital, and we treated him then to put him in a camp and potentially trade him for our Ukrainians. And we hear on the radio connection, we can hear Russian can hear us, that every time that they have even moderate, not a heavy casualty, the commander says just kill him and leave him and go away. Because the most amount of casualties we get right now, even if Ukraine, it's not when you're in a position. On the position, you're kind of in a safe blindage, safe trench, whatever. But when you're trying to get into the position and to get out, Russian drones see you, Russian artillery strike you, FPV drones strike you, optical wire drones strike you. And again, problem with Russia, it was like a picture that was published in the North American Rescue Instagram, because it's a great picture. Vitaly is a great guy. But after that, Russian proposed $4,000 to anybody who will kill my team on the front line, because they are envious that we have good American equipment in the car. So Russians is a problem, yeah. And the main lesson learned from all the statistics and all that we know by working on the front line. TCCC works perfectly if you use TCCC. If you don't use only small pieces of CCC, if you implement it as a system, everybody trains the same way, equips the same way, understand each other. But the main issue we meet on the front line is prolonged evacuation. Probably you heard that evacuation can take hours, sometimes days, and sometimes months from the position. And during that period of time, the only person that stays with the casualty on the front line is a combat medic with no medical diploma, with no AMT certification, who just get, in ideal world, 2 weeks of training, and then he was thrown to this combat environment. That's why when we came to Malta, the course was great, and we participated, and they asked Quorum to come, but Evrik says, prolonged casualty care starts from 6 hours spending with the casualty. I said, no, in Ukraine it's just a care. It's not even prolonged. 6 hours is just a care in Ukraine. It's a couple of cases where we're making wood debris because evacuation is going to be prolonged, because our stabilization center at that moment going to be struck by a Russian tank, and we cannot get out of this, and the casualty going to spend hours together with us. So you can see Nastya making wood debris and cleaning dead tissues out of the wound, and you can see the amount of wound of damage on that casualty. Just one wound on the casualty, just one shrapnel wound on the shoulder, and a pressure bandage that wasn't changed for 4 days. You can imagine the smell. And the only thing that you can ask a combat medic, why didn't you change it? Because he didn't know nothing about that. Because it's not in a CMC course, change dressing every 12 blah blah whatever hours. He was trained to do march pose in the smallest possible amount of time, not trained to do nursing, not trained to do prolonged casualty care. And I don't know what will going to happen with the hand. I hope it's going to be okay, but you understand that just another tablet of antibiotic and another changing of the dressing can change outcome dramatically. Same like cleaning wound after 12 days, staying on the front line. One more case about prolonged casualty care. That guy stood on the position for 16 hours with 2 broken arms. He couldn't, I'm sorry to say it, to get his dick out of pants to pee. And a combat medic said, I don't know what to do, just pee in your pants. So for 12 hours, adult man who could drink, swallow, etc., was peeing in his pants. You can imagine his mental status. I'm not talking about the smell, I don't care about the smell. So should we train combat medics how to place Foley catheter in the cleanest possible way? Yes, and in the CPP, Combat Paramedic Provider course on the deployment medicine, it's one of the skills that we should train. In the DCR, in the Quorum course that we train together, it's one of the skills that we're bringing in as a skill station to our combat medics. A couple of videos about evacuation, some of them more funny, I would say. So it's not about the drones, fortunately. It's about our winter evacuation in Ukraine. It's one, like we've been working in that casualty collection point for half of a year. Right now we moved to train police brigade, and the guys messaging us that the last armored medical evacuation car will get an adventure of that kind. It's the quality of the roads in Ukraine right now. So we came with an idea how to deal with this. If we have a prolonged evacuation, obviously we need to train our combat medics to prolong casualty care. And that's the reason I messaged to Evrik, and that's the reason they came to Ukraine for the first time. And then for the second time, we performed already 2 courses together. And the course was made specifically for the equipment that unit has. It's Azov units, they are like pretty noble, and through that they can get almost any kind of equipment, like fancy MOVE SLC and stuff like that. And right now we train in combat medics, like non-medical, non-diploma, non-nursing skills personnel, how to nurse a casualty, how to stay with the casualty with a great amount of time, how to do damage control resuscitation to win this time for your casualty. So collaboration with Quorum always deliver great results. It's one of the casualties who've been treated in Ukraine by Evrik and Nastya, and she was pregnant, yes, due to fast plus, I can say so, yeah? So it's the end of my slideshow, and we are ready to answer any question. Once again, thank you for the whole support we get from the whole of the world, and the only thing we can give back is our experience, and I hope it will help you to prepare to the future conflicts right now, because we started to do it too late, and right now we're trying to raise this time, to raise the resources, and to raise the skills. Thank you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.